Dr. Davis. Dr. Davis is professor of pediatrics and medicine. She's nationally known for her work on doctor-patient communication, and recently she's been focusing on hospital care transition. And so I look forward to a really good presentation about where we are and what the flaws are in transition. So, Sarah.
Thanks. So, I need to put on the microphone. As Kenny said, I'm new to transitions in care. I'm not new to pediatrics. I've been on this faculty for 35 years. My daughter was 10 weeks old, and I put her in a corner in one of those plastic things at that time. It was the first time I lectured to medical students. But I'm in pediatrics and medicine in the cancer center. I'm a psychologist who at one time, when we had an adolescent clinic, saw adolescents here as a part of a team, and then I began to do just research. And mostly research in how we communicate, not only as providers, but in public health and in systems with patients so they understand what we intend to communicate and that it's useful to them, that they can act on it. They don't have to just, they're not writing a term paper on it. They have to do something with the information, most of the information that we give them. Now, my expertise is in health literacy, and because of that, I was asked to be on this national PCORI grant on transition of care from hospital to home. Now, this involved Medicare patients, but in doing focus groups, and I did 8, but 40 were done all across the country, there's so many parallels with pediatrics. And then I reviewed the literature for this grand rounds in pediatrics to see what's going on with, you know, they don't make these for women. You know, if you don't have on a suit or a lab coat, I guess you're just kind of out of it. Okay, so I have nothing to disclose for this. So here's some questions, and these are the objectives. Why is care transition from hospital to home to clinic a national priority? Why is it all of a sudden a deal? What are the problems in pediatrics? What is PCORI? I'm on a PCORI grant. What is PCORI? And why are they interested in improving care transition? What do parents and caregivers and patients experience transitioning from hospital to home? A lot of the work I did was the perspective of the parent, the perspective of the patient, not just the outcomes at the hospital level. Lessons learned from Medicare focus groups that are relevant to pediatric. What's working? Components of successful discharge. Hello, Alice. I see some of your residents are in my yoga class, and it's fun to see them when they don't have on their yoga pants. And then as a bonus, these pediatricians, where's Herbs? These GI pediatricians from Wisconsin called me and wanted help with health literacy. I said, send me some stuff you're doing. And they sent me this cool cartoon that gives consent for a colonoscopy. If we have time, I'll pay you the cartoon, because I think I would like to do something like that here. I think it's just very clever, and it wasn't, you know, movie stars that did this. It was pediatricians, GI pediatricians. So care transition, hospital, home. Why should you care? Successful care transitions are a priority nationally for pediatric and adult medicine. ACA, Obamacare, created incentives and deterrents to address care transitions. In adult medicine, Medicare reimbursements penalize hospitals for high readmission rate, congestive heart failure, pneumonia, MI. In pediatrics, avoidable hospital readmission and ED visits, avoidable ED visits, is a quality indicator, and that's an important thing nationally, quality indicators in these departments. Discharge planning, multifaceted interventions enhance patient outcomes and reduce 30-day readmission 20 to 40%. So we'll go over some of those that are working. So there's a perfect storm of patient safety, and that's really what the problem is. There are about 39 million hospital discharges a year. Almost 20% of patients, pediatric and adult, have a post-discharge adverse event, which brings them back up here. 20% of adults are readmitted within 30 days. 6% of peds. So y'all, I mean, kids are more resilient. Y'all doing a little better job. Hospital discharge is not standardized across the country. They're loose ends. Pending and post-discharge test, communication with the primary care provider, English is a second language. I was looking for OB data yesterday, and 20% of our OB patients are Hispanic. Is that true in peds? Anyway, it's coming. Health literacy is a problem. Poor information, discharge summary quality and availability, poor preparation of parents and patients, knowledge of diagnoses, how to take your medicine, when your next appointment is, and fragmentation, I think, is the #1 problem. Who's in charge and who do you call? So why should you study this? Most care transition studies in the literature are focused on utilization, not what's important to parents and patients and providers. Current practice doesn't support continued and coordinated care between hospital to clinic to home. Successful discharge strategies include teaching by an individual or team with specialized knowledge of the problem that assume responsibility and are accountable for transition and offer ongoing support. There needs to be clear and direct communication of treatment plans and follow-up. So just think, as I'm telling you this, when you discharge a patient, how's this going down? Are they clear about this? What are we doing? So the most common 30-day readmission is sickle cell, cancer, transplantation. What's the most common thing at LSU? I don't know, for readmission. Do y'all know? Y'all don't know. Okay. 1 in 5 families, this is in the PEDS literature, report major problems with transition. Providers, primary care providers, and hospitalists report problems with discharge communication. How are y'all doing communicating with the PCC? If the PCP is a resident here, that's one thing, but sometimes that kind of gets loose. I know it does in medicine. And how about in the community? Poor transitions are linked to medication errors, suboptimal outcomes, increased ED visits, and hospital readmission. Patient perception of readiness for discharge is linked to how well the care is coordinated and the discharge teaching. So just think about who's doing the discharge teaching. Does the nurse know what the doctor's doing? The PT, whatever, whoever is on the team, is that care coordinated? So this is the pediatric literature, and so it's 6% readmission, but I thought this was interesting. It really doesn't vary by insurance or race, varies mostly by diagnosis. So this was 72 children's hospitals when they control for the child's age and their chronic condition. It's about 6%. So I tried to get, you know, I'm having trouble with UH, with getting numbers out of them and finding out who to call to get the numbers. So I found out that there were 1,500 discharges, this is all patients, per month. 200 are readmitted within 30 days. The readmission rate is 17%. That's better than it is nationally. Their goal is 14%. But I couldn't get a straight answer about I said, I just want pediatrics. It's pediatric talk. They don't care about what's going on in medicine. So she said, well, we have 2,751 admits, but we have 3,435 discharges. I said, that doesn't make any sense. And then this is per month, and I said, I'm just looking for the rate. And she said, well, this is what we have.
Is that the nursery?
Newborns.
I bet it's the nursery.
Okay, so you can be discharged. If you come in and your mama, then you're not admitted, you're just discharged.
And also they might...
Your mother is admitted. Okay, that's a good point, Colleen. I couldn't figure out what this meant, but at any rate, it didn't help me get the rate Is it 6% here? Is it 5? What is it? Who knows? So poor transitions lead to suboptimal outcomes. Common consequences, getting worse, medication errors, adverse events, unaddressed test results. I don't know how often that happens with your patients. Failed follow-up appointments and testing. Excessive rehospitalization and emergency visits. Primary care provider dissatisfaction with communication or confusion regarding discharge responsibilities. Patient, caregiver, family dissatisfaction. So this is a study of 51 parents in 5 transplant clinics. This comes out of the people that sent me the cool cartoon were also coolly doing transition of care, and so it was just a real neat kind of loop. But I found this article by one of those GI people, and most people are white bread. Median age of the parent is 35, the child was 3. They had been in the hospital 14 days. Seemed like a long time, but if it's transplant, I guess that's the way it is. The medical needs at discharge with these transplant patients, over a third needed wound care, tube feeding, central line, and drainage tube at discharge, going home on this. Care coordination and quality of discharge significantly associated with parent readiness for discharge. They interviewed patients in the hospital, the parent, the day of discharge, and then they called them at 3 weeks, 3 months, and 6 months. At 3 months, readiness for discharge was linked to the parent's ability to cope with difficulty and adhere to medication. So the quality of the discharge teaching and the plan for outreach and support is related to how well the care is going down at home. So the American Academy of Pediatrics said the provider's perspective is discharge readiness is based on established criteria for safe discharge, may be impacted by reimbursement. Parent perspective is the preparedness, do they feel prepared? Do they feel that they can care for their child? Are they confident? Do they want to go home? Are they ready and wanting to go home for recovery and care? And the AAP perspective, they recognize that PEDS patients are discharged in an intermediate rather than latter stage of recovery. So discharge assessment should extend beyond criteria for physiological status to conscious declarations of capacity of the parent and the patient, they're old enough, their ability, the availability and accessibility of support in the community and with other families. Who's helping mom? Is she a single mom? Who's going to be helping her? So what are the reasons parents don't receive or assimilate discharge information? A lot of times y'all tell parents, but they may not get it. So this was at a Cincinnati Children's Hospital. Almost half were non-white, and over a third, it was probably a single mom, only adult, or grandma, only adult in the home. More like our population, probably. So what the parents reported, they were in a fog. When you come in here, you forget what day it is, what time it is. You feel mentally exhausted. Parents had trouble processing and acting on the information that you give them. They may be reluctant to ask questions because they perceive a lack of your time, lack of continuity in the staff. Maybe it's different doctors, residents, medical students, nurses, pharmacy students every day. So a lack of continuity in staff or feeling they've already been told the information. What information I wish I had? Parents and providers may have different perception of what's important. Parents wanted details on red flags to look for at home and how to manage recovery. They want you to be clear and use consistent terms. They wanted those consistent terms across providers. So if one doctor's using one term for the same thing and another one's using another term, if you use consistent terms, it's helpful if it's not your usual vocabulary. Am I ready to go home? Parents' confidence and expectation about their ability to care for their child at home, cope with changes, handle uncertainty, may not be in sync with your judgment of their readiness. I'm home, now what? Confidence and ability to care for a sick child at home. Who do I call? So, parent readiness for hospital discharge. This was a children's hospital, mostly white. This was out of Wisconsin too, I think. So the child was, average age of the child was 7, average stay 11 days. Over half were planned, 40% were chronic disease. Over 30% it was the first admission. Delivery, discharge, teaching by a nurse, designated nurse, was the only significant predictor of parent readiness for discharge. Does the nurse do the discharge here, or does the doctor, the resident? Nurse, okay. Utilization reflects ongoing needs of parents. 34% called family and friends to get some support. Over a third called providers. 80% had an office visit. Over about a fourth were unscheduled office visits. A third called the hospital. If you call back up here, who do you get?
The residents.
Or do you know who to call?
Yes.
Call floor. Okay. 16% ED visits, 15% readmissions for this study. Unscheduled visit concerns, medicines, crying, feeding, incisions, pain, respiratory problems, constipation, seizures, and equipment. Are those the kind of problems y'all get calls for? Any other problems that are common? Get calls on? Y'all whispering?
Prescriptions.
Prescriptions, okay. So here's some common adult patient experience hospital to home. I felt like different people I was seeing for my care were not communicating with each other about my needs. It seemed people did not really care about me as a person. I was treated more like a number than a person. I felt like I really needed to talk to a health professional, but I didn't know who to call. I went to a doctor or a nurse or a technician who seemed not to understand my healthcare needs. This is a follow-up visit. I went to a test or an appointment and found out they didn't have much knowledge about my health condition. I had difficulty getting the care I thought I needed. I had to explain my health condition every time I saw somebody new. I felt downhearted and blue. So parent caregiver reported distress, fear of harm to patient safety, and poor transitions. Caregiver feelings were guilt, worry, overwhelming burden. They were afraid that they were unable to care for the child or their adult parent and something bad would happen, that the safety of the patient was in their hands, and that was very frightening because they thought if they messed up, something bad could happen. Many of them felt abandoned, and consequently, some of them had depression and anxiety. So the American Academy of Pediatrics hooked up with, well, there were 8 organizations: American College of Physicians, American Academy of Family Practice, and they called this initiative Stepping Up to the Plate. And these are principles and standards of managing transitions in care. They said there was little work focused on improving coordination of care across providers at different locations. Timely information should be exchanged between providers and sites of care as quickly as possible. When I did focus groups in rural clinics, a lot of times they weren't getting the information back from the hospital. Now this was in adult care in a timely way. What medicines had the patient been on? What was the plan? What did they want the PCP to do? At every point, patient needs to know who is responsible for their care, who to contact and how to contact them. From the patient perspective, I love this: nothing about me without me. Personal clinician, this is why I thought of Dr. McVie, personal clinician accountable for ensuring patients of all ages experience effective transition and timely exchange of communication. Now, I went in to see Dr. Bocchini and to discuss what was happening in pediatrics, and he said he thought Dr. McVie was doing a very good job. So I called him and I said, I'm calling you out doing grand rounds. So what are you doing that Dr. Bocchini thinks is effective?
Actually, I don't do too much. Can I come up?
Yes, come on.
Here or there?
Wherever you want to be. I want them to hear you.
I can talk pretty loudly. Can anybody not hear me? If you can't hear me, put your hand up. That's the kind of thing we do with English. If you couldn't hear me, you wouldn't know to put your hand up because you probably couldn't read my lips, right? Okay. What do we do? Well, number one, I have a really great educator, a dietitian educator, and a nurse educator who spends hours with the patients. Number two, in transitioning and getting ready to go home, we make sure they've given shots. We make sure they've drawn up the insulin. It drives us crazy when that doesn't happen. When the patient is there and somebody's just written the order and hasn't said to the nurse, teach them how to do it. Show them how to draw that insulin up. That's important. They're doing it at home. Unless you want to go home with them, I'm not paying you to do it. One. Number two, prescriptions. Very often, pharmacies freelance. Or, oh, we don't have the insulin today, but you can pick it up tomorrow morning. Well, the patient needs insulin tonight. So we're calling up to make sure that they actually have the insulin for the patient. Or they give them syringes. Well, any syringe will do. Unfortunately, many of our patients need eighths of a unit of insulin. And if you don't have a half-unit syringe and diluted insulin, you can't give an eighth of a unit. And I've had pharmacists tell me, nobody needs a half-unit syringe. I disagree. And I tell the patient to go somewhere else. But, and then, I can't think of enough things to tell parents not to worry about because they're going to worry about everything. Is anybody here a parent? Yeah, there's a couple of parents here. When you take that newborn home, even if you're a physician the first time, you think you're going to kill the thing, right? That's pretty much what we do. That's how our minds work. So you take a child home that has come out of the ICU with a pH of 6.9 or 7, and the doctors have thanked you for getting them in before they were dead. And they've taught you some things that we can give them these shots that do something to their blood sugar. You are in terror. And I can't tell you exactly how much insulin your child is going to need, morning to night, different times. Because the insulin need is going to change dramatically as children get over their glucose toxicity. So, Dr. Gungor is called. Dr. Nambam is called. Emily, our PA, is called. We're on call. We're on call for that. We try to get the people to call us between about 6 in the morning and 7:30 so we can drive to work, and between about 5 in the afternoon and 7:30 so we can actually go to bed and sleep at night. But we get calls at all sorts of times and hours for all sorts of strange things that we wouldn't anticipate the parent would be worried or other doctors get worried about. I have had calls from doctors. The urine sugar is 2,000. Oh my God, what's the blood sugar? 150. You know, we don't use urine sugars really anymore because they don't reflect the blood sugar except in a very indirect fashion. And if the blood sugar was high after eating a couple of hours ago and the kid's peeing now, that's what you're seeing. It doesn't matter. But people can get themselves worked up about a lot of things. Oh my God, the blood sugar is 300. Yeah, before he was diagnosed, his blood sugar was probably 1,200 when he had that Coke that he got from McDonald's in that big cup and drank it on the way in. It's a number. What's the child doing? We make ourselves available so the parents can call us and talk to us. I don't know another way to do it, and I've been doing that for 38 years here. And when I was in New York in my fellowship, that was what we did. So,
I think that's great. One of the things I want to underline is, as a physician, you're a learned, or a pharmacist is a learned intermediary. You know how to put things in context. The parent goes home, they're afraid, you've taught them some numbers. If the number isn't in the range you've taught them, they're going to get scared. And they don't have the context that you do. And so that's why it's important. They know who to call, what number. Obviously, if you've trained them to call you at certain times, that's helpful. So that was great. Thank you so much for sneaking out of clinic. Do y'all have any questions for Dr. McVie before he leaves? It's a good model when you get in practice. Oops. So I want to tell you a little bit about PCORI and some stuff we found with adults that I think are very applicable to peds. So PCORI is a new kind of federal research. It's not NIH, but they fund large, pragmatic trials. It was a part of ACA. They address questions that are relevant to patients, physicians, and healthcare decision makers. And the goal is to move clinical research, I love this, from the bookshelf to actual use. So to do this, they believe you must engage a wide variety of stakeholders. Now, a stakeholder is a parent, they're a patient, a provider, a funder, people who have something in the game, to make the clinical research more useful to society and change how healthcare is delivered. A lot of research is just sort of wasted. Some of it's not even written up, but even if it's written up, is it actually used and is it practical? The premise is research is more likely to improve patient care if patients, providers, and other key stakeholders are involved in all aspects of the research. Not just being tested, but help design it and help define what needs to be studied. So PCORI identifies critical questions in healthcare. Transition of care is one of their top priorities. Funding began in 2013. They funded $289 million for 162 investigator-initiated projects. And they got to go to Congress in 2017 to justify the work. So more and more, everybody's having to justify everything we're doing, and they're having to justify that federal funding for this is actually being used. So their rationale is traditional medical research hadn't addressed many questions patients and clinicians face daily, or make the findings easily available in ways that patients and providers can understand and use. So they only fund comparative effectiveness research that focuses on patient-centered outcomes. So they have 13 projects for $64 million on transition of care. Now, I'm on a project called Achieve. They were funded for 3 years for $15 million. It's out of the University of Kentucky. And their aim really is to identify transitional services and healthcare outcomes most important to patients and caregivers. So I just thought those of you who are doing some research, this is interesting. They gathered a national multidisciplinary team. We talked numerous times a week, reviewed the literature, conducted 40 focus groups, conducted 50 hospital site visits. And that includes rounding, talking with the MDs, the RNs, not just the CEOs. Developed a survey for patients, caregivers, providers, and hospitals. They're going to give this survey to 12,000 patients, 7,000 caregivers, and 30,000 providers. So they're trying to figure out what is happening nationally. It's a descriptive study. It's not an intervention. And LSU is involved, Kaiser, UPenn, Boston University, WestAd is the people that make surveys. Telegen is Medicaid, Medicare quality program out of shop out of Colorado. So what kind of focus groups are you going to do if you're talking about transition of care? Well, I did the ones in rural areas. Connie Arnold and I did. Some people did mental health focus groups. Low SES, we did that. Low health literacy. Others did limited English proficiency. Some of them did dual eligible. I did mostly Medicare, cognitively impaired, multiple chronic conditions. And so we had a good variety of patients. And so what's important? Here's the bottom line for y'all. What's important to patients and caregivers? Patients and caregivers wanted compassionate, supportive communication, wanted you to anticipate their needs when you got home, transportation, medicine, equipment, follow-up services. You heard Dr. McVie. Can you get the insulin tonight? Can you get it in a syringe that's useful? And what is their responsibility? They wanted shared decision-making, coordination of care to foster continuity, coordination between providers, and access to timely appointments. When's that follow-up appointment? And trust. Trust was huge. Being known, feeling cared for by healthcare providers. So here's some bottom lines from the focus groups we did in Louisiana. Relationship with the providers was important. Continuity and trust are key. One of the reasons transition of care is a national deal is, how many years ago was the same doctor saw you in the clinic as saw you in the hospital? Now we have hospitalists. And so you have a different team in the hospital, and every time these adult patients said, every time I'm hospitalized, there's a different team in the hospital. Those people don't know me. They don't know my health. They felt like their primary care provider knew them and really cared about them and knew their health history. They didn't feel that the hospitalist knew enough about them. So they felt connected to the primary care providers, and they had confidence in them. They trusted them. Trust was something that just came up over and over again. Didn't feel like the hospital staff knew them. Less inclined to have confidence in the hospital staff or to trust the discharge plan. Doctors never spent enough time with me in the hospital. They didn't know anything about my body. Physicians at the hospital are always different with each admissions. You didn't see a familiar face. You don't know anybody. They don't know me. They don't know anything about me. Caregiver concerns, not being in the room the 5 minutes the physician's in the room, which is a problem. And then the patient may not be clear about what the physician has said or remembered it. I mean, several of y'all have to be caring for adult parents and who are maybe repeatedly hospitalized, and this has to be familiar. So patient advice, have someone in the hospital to look after you. A caregiver needs to be in the hospital with you, and in peds that happens. And in case you miss anything, you can't grasp everything they're telling you. You're sick and you're going to miss a lot. So complaints about medication after discharge, and Dr. McVie outlined that beautifully. Many patients got put on different medicines in the hospital. They take you off everything your primary care provider put you on. Many were not clear what medicine was for or how to take it. When they give you the medication, they don't explain it. The insurance companies sometimes won't pay for the medicines the doctors put them on, the new medicines, and nobody checks to see if they can pay for it or if the insurance they're on can pay for it. Nobody ever asks if you can afford it. Difficulty getting medications needed at home in a timely manner. Pharmacy reported they hadn't received the fax, even though the hospital reported faxing the prescription before the patient were discharged, and I heard that repeatedly. Caregiver frustrated with the timeliness of being able to pick up the prescription after. If you discharge somebody at 2 or 3 in the afternoon, you get them home, somebody's got to then go to the pharmacy. If you're a single mom, how does that work? So somebody needs to have anticipated those kind of problems. So patients and caregivers report communication that's supportive and communication that's frustrating. Supportive was transparent, actionable, empathetic, respectful, timely, collaborative, and purposeful. Frustrating was unpredictable, conflicting, condescending, unilateral, and hurried. So what makes it good? Supportive and empathetic. Providing emotional support and empathy fostered the trust in the team and in the care plan. Providers, this was really sad to me. They wanted providers who sat down and were not rushed. All of y'all are rushed, but really good clinicians know how to appear not rushed when they go in. Like, they have all the time in the world for you and they really care about you. Collaborative. A sense of being included and involved in medical decision-making, encouraged to talk. You can't be rushed, and invite somebody to talk and ask questions. Permitted and comfortable asking questions, including the appropriateness of the care. So I thought it would be fun for me to read you some patient quotes. This patient had a good experience. The doctor who was leading the internal medicine team encouraged me to talk. When she was in there with the students, encouraged me to talk to the students and to her. You know, she wanted my input on what they were discussing and what was going on, and it made me feel empowered in terms of my health care. Most doctors don't encourage that. They just want to come in there and tell you what they need to tell you, and they want to leave. They're done with you. But you know, she wanted to talk. She wanted to listen. You know, she fostered a good environment to be able to speak. So here, this is a caregiver talking about these kind of things. I think the doctor just really, and this is what McVie was talking about, the blood sugar is 300. Oh my God, what's happening? Well, it was maybe 1,200 before you came in. I think the doctor really just assuring us that it was normal for a person her age to have that type of reaction to a UTI, you know, just explaining how it's an infection, and that's initially helped put me at ease, right? Because having my mother talking about my dead father, if he's alive, was very disconcerting. And I didn't know what to think. So without a learned intermediary, you don't know this is normal or not normal or what it means. Giving details about hospitalization, details about discharge and post-discharge process. Diagnosis, test results, treatment, discharge plans, education and instruction, medication, wound care, follow-up care, expectations. What do you need to do to take care of your child? Giving information about potential side effects and pain and how to manage it. Giving timely, predictable information. And then using teach back to confirm understanding. Tell me your understanding of what you're going to do when you get home. Tell me your understanding what to do if this happens. So the doctor will say something, and then the person or the caregiver or the patient or whoever will just sit there and go, I know you'll experience this all the time. Okay, okay. Well, then they get home and they're like, what'd they say? What are they talking about? I didn't understand that. They're afraid to ask. I didn't know what to ask. Speak to me in layman's terms. Bring it down to my level. I'm not a doctor. So I think that happens all the time. You give information, they go, okay, okay. And then you get home and think, what am I going to do? What'd they say? This is a patient talking about valuing the teach back. The nurse would go over the medications, always, the whole list, even what I had at home. And the nurse asked, do you still take this? How do you take it? Do you know the dose? Do you need refills? How many times a day do you take this one or that one? The whole schmeal. They were just kind of assessing whether I knew, going over each medicine. Collaborative communication was very important to the caregivers. Inclusion in the history taking, the patient may not tell you everything. The discharge planning, what to expect in recovery, medication management, discharge plan. Elicitation of their expertise about the patient's needs and illness experience. What do they know? What are they able to do? Can they do it when they get home? So this is a caregiver talking. They could have told us more specifically what to expect with outpatient ECT treatments. They couldn't give us a phone number of somebody to call in the ECT department to get any questions answered. The lack of communication with the whole family with me was just astonishing. They could have told me what their observations were about Jim's mental state, their observations about his improvement. All they ever said to me when I asked them the question, did they think he was getting better? They said yes. It didn't strike me as quite enough. I always felt that I was getting in their way. I was being blown off when I asked them questions. I wasn't getting the information about what I could do, and I wasn't feeling ready to bring him home. So here's another caregiver. For me, it was confusing. No medical experience. Didn't know what the medical care was going to be. First thing I was observing was the case management nurse had made all the decisions without my knowledge. So I'm under the impression she's going to a skilled nursing rehab facility. And I didn't have time to go on the internet to do the research because, see, I'm working an 8-hour job too. I was totally in the dark about what to expect. You actually just go into it out of love. But at the same time, you're disorganized, you're confused, you feel displaced. You really don't know what to do and what to expect. So they don't like it if the information is conflicting, if it's not clear, and if the terms are not consistent. Different doctors or nurses providing contrary information. So do you know what the other team members are saying? Or their skill, their expertise in diabetes or whatever, sickle cell, whatever the problem is. The competent caregiver at home is not always available. Parents can feel abandoned, perceived providers as not concerned. It doesn't sound like that happens with McVie at all. Anticipating needs, transportation, medication, follow-up care. So I love this. It's clearly adult, but I thought this was funny. This is about transportation. See, everyone thinks I have people waiting around in cars or I drive. That seems to be, I haven't driven since '76, and all my friends are workaholics, and getting them to tear themselves away from anything for more than 5 seconds is almost impossible. And I had a hell of a time with the doctors, like I'm supposed to have someone take me home after surgeries, but I don't have anybody. So they were doing all this trick stuff to keep from putting me under. So it's like transportation is a huge problem, and sometimes providers are not as aware of that as they need to be. Anticipating needs, feeling safe, supported, prognosticating possible challenges, clear plan of action. So there's so many things you don't realize you're not going to know until you're in the moment of not knowing. In the hospital, when you are asking 100 questions, so you feel like, okay, I must have everything, I must know. And it's not until you get into the wilderness at home that you realize, oh my gosh, this isn't working out well. It's that person in the middle that notices you're going to need this, or comes to the house and says, you know, how are you doing with this? I think it's also after the hospital that you end up discovering the vastness of what you don't know. It's so many little things, like where am I going to sleep if I can't get up the steps? And Colleen, I'm sure when you took your first baby home, there were so many things, even as a pediatrician married to a surgeon, that you didn't know, that you were sort of in the wilderness.
Less than what, because people assume you know, and so when you're being discharged, they may not do the full discharge that they should do. When we were discharged from the NICU, it was very good, and we had a NICU, our discharge nurse did a really great job. Being discharged from the nursery was a little bit different. Not that it was a bad job, but I think they just assumed that we knew everything, so they just handed us stuff. So it's just different because they think you already know everything.
So, bottom lines on that, dear, clear communication, education, accessible phone numbers, post-discharge contact, arranging before discharge follow-up care services, transportation supplies, training in the skills that they need to have. I want to tell you briefly about Project RED. This came out of BU. This was adults. Their aim was to prepare patients for hospital discharge. It involves pharmacists too. So there was a nurse discharge advocate who worked with inpatients to educate them. They developed a booklet for them. They arranged follow-up appointments, confirmed medication reconciliation. Took her an hour and a half, 45 minutes with patients and 45 minutes to review with the team and develop the booklet. The pharmacist called the patient 2 to 4 days after discharge to review meds and reinforce the discharge plan. The average time for that was 26 minutes per patient, about 20 minutes of counseling. 65% of patients had at least one medical problem. Now, when I gave this talk a couple of years ago about Project RED at Ochsner, they said there's no way in hell Ochsner would allow a nurse 90 minutes to do this. But here's part of what the booklet looked like. Here was a page on the medicine. What time of day do I take this? Why am I taking it? The medicine's name and amount. How many do I take? How do I take this medicine? Very clear cut. Then here's their appointments. Who are they seeing? Where's their address? What's their phone number? And my main medical problem is chest pain. When are my appointments? You're seeing primary care, rheumatologist, and cardiologist. So what did they find out? Failure to take medicine. This was the pharmacy feedback. 15% of patients didn't think they needed the medicine. 17% didn't fill it due to cost. 11% never picked it up. 12% didn't get prescriptions on discharge. Do y'all give prescriptions or do they have to go to the pharmacy and get them? They have to go to the pharmacy. Okay, and if they live in Coshada or Faraday, or you just hope the pharmacy has what you're prescribing. And 8%, they didn't have the insurance. About 1 in 5, wrong frequency or intervention, wrong dose. Over 51% experienced an error within 2 days. So what they find out, they had a randomized trial, half the patients on this Project Red, others half on standard care. Mean stay was 2.5 days, mean age was 50. A lot of them had low literacy. So with Project Red, there was 30% lower readmission, 30% more likely to follow up with a PCP, and 34% lower cost. And it's been, now it's a safe practice for hospitals. So 94% had, with Red, had scheduled an appointment. They had given the plan to the patient. How did they do? What was the fidelity of it? They did pretty good, but it wasn't 100%. And only 60% of the pharmacy calls were completed. But the readmission rates were significantly different. ED visits, PCP follow-up, and able to say what their primary problem was. And the total hospital utilization with ED visits and rehospitalization was also significantly different. So here's the summary bottom lines. Quality discharge teaching and personal follow-up is key to effective transition. Supportive, empathic, transparent, purposeful communication using consistent terms fosters transition of care and trust of the team. Anticipation of home care needs is important. Decision-making needs to be shared. Remember, nothing about me without me. Care needs to be coordinated and foster continuity. Parent and caregiver feeling prepared, confident, and safe and supported at discharge is key. Now, I want to show you this video as a cool patient. This is totally not about transition of care. Herbs, this is about colonoscopy. And this is something they designed. This is about 3 minutes in
Hi, I'm David. I hear you're going to have an endoscopy. It sounds intense, but it's actually not that bad. Let me tell you what it's like. There are 2 different kinds of endoscopy, upper endoscopy and lower endoscopy, or colonoscopy. You may be having both. You can eat a light breakfast the day before the test. After breakfast, you can only drink your favorite clear liquids. You can drink any clear liquid until you go to bed the night before your visit. This will help you stay full of liquids and not get too hungry. The day of your test, you cannot drink or eat anything. That can be tough. But don't worry. As soon as the exam is over, you can eat whatever you like again. When you wake up, the nurse will give you a snack. I got a popsicle. When you're getting ready for your colonoscopy, before you come to the hospital, you'll have a drink that'll make your intestines all clean. Your doctor may also prescribe a medication, but don't worry. You and your parents will get all the instructions before your visit. You can pick any of these different clear drinks. Gatorade is my favorite. These drinks won't help you, so stick with the clear liquids. To make the special drink, you mix polyethylene glycol with your favorite clear liquid. You have to drink it pretty fast. I drink 1 cup every 15 to 20 minutes. If you get tired of drinking, make a game out of it. I like to watch a show and drink when the commercials come on. If your tummy hurts or you feel like you might throw up, just give it a break for a bit and try again. It's really important to make the intestines all clean. After you've started drinking the special liquids, you'll need to go to the bathroom a lot, but it's okay. Don't be surprised if your poop starts to look different too. When your poop is clear and watery 2 times in a row, you're ready to go and you can stop drinking your special drink. When you get to the hospital, you will dress in a hospital gown. It's pretty comfortable, like a bathrobe, and it makes it easy for the doctors and nurses to help you. To start, a nurse will bring you into a procedure room, like this one. There's a lot of cool stuff in here. Next, you will meet an anesthesiologist. Wow, that's a long name. They are a doctor who will give you medicine to help you fall asleep. That means that you get to sleep through the whole thing. And when you wake up, you won't even remember the endoscopy happening. Cool, huh? But it still helps to know what's going on, so I'll fill you in anyway. Oh, I forgot to introduce you to Scopy. What's up, Scopy? Scopy is a long camera that the doctor will use to look inside of your mouth, stomach, and intestines. Let me show you how he works. During your lower endoscopy, the doctor will send Scopy in through your bottom, you know, where the poops come out. The doctor will look at your large intestine and part of the small intestine. Did you know your large intestine is almost 5 feet long? Scopy will look around and take pictures and pick up little biopsy samples for the doctor. When you wake up, your family can come see you. You might be sleepy for a little while still, even after you go home. So chill out for as long as you need to. And remember to milk your parents for as much special treatment as possible. I was able to get lots of ice cream. An endoscopy is a very safe procedure. When you wake up from an upper endoscopy, you may have a bit of a sore throat and feel gassy, but that gets better very quickly. It is very, very, very rare, but possible, for kids to have some bleeding, get an infection, or need a surgeon to fix a tear in the intestine. Most of the time, you get to go home in a few hours. If the doctor took samples, they will be looked at under a microscope, and your family will get the results in 5 to 10 days. I'm glad we were able to hang out for a bit. If you have any questions at all, you can ask the doctor or nurse. Well, I guess I'm done here. That wasn't bad at all. Time to go home now. Bye.
So that is the consent. And I thought it was a very cool consent. It just kind of, the animation, the doctors wrote it. I think they could have used a little more plain language, but I thought it was, the quality was really good and the animation was clever. It was engaging, and I think it would engage a kid and help inform the kid and their parents and make them feel safe and a little more comfortable. So do y'all have any questions about transition of care or cool consent? Yes, Arun?
That was an excellent overview. It's a very important subject, and we face this problem all the time. Discharge planning, if you read any standard textbook, all your pediatric really should start once the patient is stable in a critical care unit or in a ward. From the day of admission, the plan has to start.
Not the hour of discharge.
Not the hour or the day of discharge, number one. And unfortunately, over my years of experience, that has never been done, including the fact that we had a discharge planning nurse. One of the problems we discussed in our section yesterday, because of the wisdom of the hospital, they have taken off the discharge planning nurse. We were finding that we were getting information, babies we were discharging, that should have been picked up. Because one of the problems of intensive care doctors like us is the transition, we're not taking care of the babies subsequently. So that's really a problem. Maybe Dr. Bocchini can help us in that area because serious diseases could be missed. In your slide, I noticed that, and I believe Children's Hospital Wisconsin 2008 publication, that wound care was the #1 reason for readmission. I would have ventured to guess that it's respiratory problems, as we are saving smaller and sicker kids, perhaps. RSV immunization may have changed that, but or maybe it's a children's hospital where they're doing too many surgeries, transplants, cardiac, so the data is skewed, in my opinion. Again, from my experience talking to my colleagues, the West Coast is pretty well advanced in terms of the continuity of patient care communication, because as you showed, Kaiser has data that goes from before birth to adulthood, and doctors
Kaiser's doing a pretty good job.
Pull it up. Again, my relatives and friends who live on the West Coast, one of their complaints is they don't see the same doctor. It's not possible in modern managed care things. So getting back to your presentation, have you looked at, since you focused on the rural areas, what is our problem? Because one of the problems we face or several problems we face. The two major ones is transportation, as you alluded to, from rural areas. That you have to go to the Medicaid office, which is located in Monroe or some other parish. Number one, different social workers. Number two problem we face is a lot of our mothers may be on drugs. That some adult doctors or family doctors or GPs are prescribing, but the mom's never taken it. For instance, and one of the major things I wanted to allude to is painkillers or antipsychotic drugs, and she takes it when she feels like. So that's why your thing is so important at high speed. The last punchline I want to leave you with, that your excellent presentation would be very helpful if you coordinate with the hospital to get all the nurses, respiratory therapists, pharmacists, because they are the ones involved, should be involved as you presented at the time of discharge. And I know the AAP has the what is that, the continuity of, what is the program called? The
medical home.
Medical home. Yeah. So I don't know how well it's working in Louisiana, because you and John are involved in the AAP of Louisiana, but they have been emphasizing that for the last 5 years, to my knowledge, at least.
Oh yeah, long time. Yeah, yeah, and I think that this is obviously a very important subject and something that's faced every day. And so I think this kind of work is really important, and kind of like deja vu all over again. The same principles that you have in trying to establish a therapeutic relationship with a patient. Remember, like, in some cases, it's much easier to make a diagnosis of diabetes than it is to then manage that patient for life on what's the best way to manage that patient to minimize the outcomes that are negative related to the chronic illness, and to make sure that the child has a normal life by controlling the problem. And so it's really important that you establish that therapeutic relationship, and these are the principles that you need to use to make sure that that happens. And so, and you can say that for any child with an acute illness that needs care after discharge, as well as any chronic illness that's going to be a problem for lifetime. So I think this is really important. And I think the medical home and establishing the relationship between the subspecialist or the people who took care of the patient in the hospital versus the PCP is really important as well. And I think this sort of highlighted some of the really important issues that you got to address every time you're planning to discharge a patient from the hospital. John?
Just a couple of quick observations. This is excellent presentation. One of my favorite stripes here is we talk about getting medicine, Dr. McVie, and just get the supply when you go home. I still can't understand why our hospital doesn't give a supply of the drugs they're going to need at the time of discharge. Studies have shown that the nurse says, this is the medicine you're going to take. Look at it. And do it. It dramatically improves the compliance. I think you do need to follow up. I noticed that one of your studies, there was a children's hospital. I think the average length of stay was 11 days. It must have been the transplant centers or something, because I think our average stay is only 3 or 4 days here, which means that we're doing much more the acute problems, and it's very hard to get may not have as many long-term problems with follow-up. I think it may be a slightly different thing. And I think that when they're trained, it's important to have what I like to call the white glove inspection. In other words, you can go in and teach them, but then ideally, the nurse comes in and says, okay, you're going to do it. She stands back. She doesn't make any comments, just observes. And if they can do it, then you can say to them, yeah, you did well on that. You know how to do it. You're now competent. And I think that so often you go in, well, here, just do this, and you walk them through it, but they may not be competent. So I think these are some things, simple things we can think about doing here.
Well, we have focused on patient education when the patients are being discharged from the hospital. One of the things that was done was to develop, because asthma is one of our common causes of admission, there is we have a brochure, we have information for parents, we have an educational session that is between the nurses, the physicians, and or the pharmacy trained individuals who then talk to the families and try and educate them, as well as make sure they have an action plan. And so that is something that has to be duplicated for virtually everything.
I think this helps explain why nationally, people talk about the hospitalists. I think they're good and they're useful, but when I go to my GI meeting, most of the patients that come in on a GI service, it's the gastroenterologist doing the primary doctors in the hospital. So much is going to be done. They're going to be seeing them in follow-up. And I think the payoff is that the parents are much more likely to feel that the doctors know what's going on.
So one of the things that everybody needs to be aware of is that recently University Health did establish an outpatient pharmacy, which is over in the clinic, and so that your patients can go, your parents can go to the pharmacy and pick up medications there so that they have them before discharge. And I think that's one important way to make sure, because I think Terry's right, if you have a patient comes from a small town and you order medicine for a pediatric patient, it's very likely that that pharmacy is not going to have it, or it's going to have to order it. It's going to be 24, 48 hours for it.
Or they'll be closed by the time you get home in the
right.
van or
So
whatever.
This is one way of making sure your patient has it. For what we do for kids who have osteomyelitis and going home on oral therapy or any other thing, we make sure that the parents have the bottle of medicine before they leave the hospital so the child doesn't miss a dose. And I think that's a really important thing. You got to pay attention to these issues to make sure your patient gets good transition of care.
Even in my refills, I found out about a quarter of the time they're not going to have one of the medicines that I'm coming in to get refilled. And that's a big one, like a Walgreens store. So just think what it is when your patient's going home at 5 o'clock at night.
Yeah, a lot of these pharmacies don't stock a lot of drugs now. They order them from a central distribution place and they're delivered the next day. So you got to be really careful your patient doesn't miss a dose. Well, given the hour, we're going to have to stop, but this has been a great discussion following this great presentation. So if anybody has any other questions or comments, they certainly can come up front. But thank you all. Thank you, Terry.